All right, so this is part 2 of how to write a SOAP note, part 1 video that we left halfway. We're going to finish everything here. I'm going to share how to structure an orthopedic SOAP note, and we're going to dig deep on how to write an orthopedic SOAP note. Then I will share with you my step-by-step approach and process when I document findings and when I write an assessment and plan based on a real clinical practice case. And make sure that you stick around to the end because I plan to review and share the key acronyms used by ortho specialists when writing ortho notes. I want you to understand what they mean in case that you come across these notes in clinical practice. You would also learn what they are and hopefully start using them too. Also, I will share with you how to access the free must-have ortho guide for nurse practitioners. Hey everyone, it's Jessica here from NP Insiders, where I help you expand your nurse practitioner clinical knowledge and fast-track your career growth and practice, all while making it enjoyable. You've come to the right place. If you're new here, make sure that you click that subscribe button. You can find all the links and everything that I mentioned here in the description box below. So let's jump into it. I've said it before and I'll repeat it again. Good clinicians write good SOAP notes. It is your story, the story of your encounter with your patient. But I get it, writing patient notes can be a struggle, a pain, a hassle, whatever you call it. But if you learn how to do it, I promise you that it is going to become second nature. The more you practice it, the better you get at it. Pro tip. Whatever you write today will come in handy in the future and then help accelerate your evaluation when you see the patient again. So get it right from the get-go, from that first encounter that you have with your patients. So we're going to go ahead and proceed to the PowerPoint presentation where we're going to go in detail on how to write that SOAP note, what it has. We're going to do actually a real case, based off a real case, and we're going to check that step-by-step approach that we said at the beginning.
Okay, so here we have Mr. Joe Smith, a typical patient that presents to clinic, a 64-year-old male with a complaint of knee pain. Let's find out what's going on with him. Before that, let's review what we talked about last week about the SOAP note and how to structure that. You first want to do your subjective, then objective, then assessment, then plan, and basically it's an acronym for SOAP. All right, so in your subjective piece of this, you're going to have your chief complaint and make sure that you always put that in quotations. This is exactly what the patient tells you that they're here for in your clinic. Then HPI is your history of present illness. Then you want to make sure that you get the patient's medications, which ones are active and they're taking. If there's any allergies, PMH for past medical history, PSH for past surgical history, the family history if it's something contributory or pertinent, then there's social history. You always want to know if the patient is a smoker or not a smoker, if they use alcohol, or if there's any history or active history of illicit drug use. Then you want to get your ROS, which is basically your review of systems. When you're documenting, you want to try to be concise and basically document the pertinent information that you get from the patient. Like I said, you go in a step-by-step approach. So as I said, you want to document your chief complaint, then move on to your HPI, which is the story of that chief complaint. Remember that you also want to have some sort of framework. I went over old cards. Make sure that you watch that video when documenting your HPI. And you definitely want to target your questions so that you're not asking everything or you're not asking too little where you're going to be missing things. So you want to make sure that what you ask is pertinent to the symptoms or the chief complaint that the patient is presenting for. So for example, our patient came, he said that he had knee pain and the knee pain was mainly on the left. And then what questions do you want to ask? So this is typically what I ask. I definitely want to know what the past medical history is pertinent of this patient, especially if I'm thinking that this is an orthopedic concern, because I know that maybe I might want to use some sort of like NSAID. So knowing that the patient has a history of hypertension, knowing that the patient has a history of diabetes, these are things that you really want to ask and want to know and want to dig in the chart, because it's going to also limit the amount or the type of medications or the type of plan that you create for this patient, because at the end of the day, every patient is unique, and this is an individualized approach. So in this case, you want to ask also what kind of pain level the patient is having, and is it doesn't come and go, or is it constant? Those are like key things, right? Then what does the pain increase with? What makes it worse? What makes it better, right? Think about old cards again. Then what kind of history does the patient have? Having a history of like surgeries in the past is also pertinent for the history taking of a patient that presents like this. Also, if the pain has gotten worse, or if this is something like that is chronic, is this acute on chronic? What is it? So here we got that the patient's pain has increased in the last 5 days, and we know why, right? There was an exacerbation due to a recent trip here that the patient had to Disney World. He was advised to avoid oral intake of NSAIDs. That is pertinent. We know that from the past medical history, the patient has a history of hypertension and has a history of diabetes. So you definitely want to protect those kidneys. And we know that NSAIDs can increase, number one, hypertension, the patient's blood pressure, and can also affect the kidneys. And that's something that you want to know, because that's going to limit the things that you can do, or basically help you to create an alternative approach. Then he says that resting in heat makes his pain better. So he has definitely given a try of some of the easy management approaches that he has implemented. Then you want to ask, was there some sort of injury in addition to that exacerbation of walking too much? And in this case, there was no history of trauma to the area. And always, and I said this in a previous video, you want to make sure that you rule out emergencies by asking the patient if there's any history of fever, chills, redness to the area, warmth, right? Like these are things that you always want to ask. So then we go down to the medications, the allergies, the past medical history. Here you can be brief. If you got a good past medical history, and if you stated that in your HPI, well, then you can basically say, go ahead and read the HPI above, or you can list it. Then your past surgical history, especially if it's pertinent to that specific complaint, because what we're reviewing today here is a focused evaluation. Then the family history. Does this patient have a history of arthritis in his family or not? So these are things that are good to know. In this case, this patient is not a smoker, does not use any alcohol, and does not use any illicit drugs. So these are important, relevant things that you definitely want to obtain. So let's move on to objective here. All of you know, you were nurses before becoming nurse practitioners. Vital signs are definitely something that you want to obtain, right? Also because you want to know what this patient's BP is, right? Is there any temperature? Is there any fever? We know what he said, but we want to corroborate with the objective findings that we obtain. So here we're going to document the examination, and we want to try to be concise and also again pertinent to the information of the patient's major chief complaint. So here you can have something like general assessment, perhaps lungs. Very easy, because you're not, especially like if it's a very focused assessment and you're just going to evaluate the knee, you can basically evaluate the patient's lungs either by listening to the lungs, or if you're in a hurry, you can just see if the patient is in any arrest, right? Or if just he's breathing normally and is non-labor. So you can be as brief as that, or you can actually go ahead and auscultate. Then the musculoskeletal assessment, this one I do recommend to always evaluate the other side, just so that you know basically what you can compare this with, because sometimes for a lot of patients it's normal, something that might not be normal for someone else. So having a baseline of a knee that feels okay versus a knee that doesn't comes in handy and brings in a lot of information. So from our findings here, the patient was pleasant, cooperative, he's alert oriented ×3. He had a regular rate and rhythm when we checked his cardiac assessment. The lungs were clear. He's not breathing hard, non-labor breathing to room air. He's able to ambulate, but he uses a cane on the left hand. And this is very important, and I'll tell you when we get to the plan, because hint, the pain is on his left knee, but he's ambulating with a cane using his left hand. So he's literally putting all that weight. So then we go to the left knee. Then here you want to make sure that you document the skin, right? Is it red? You want to rule out those emergencies first. Is there any swelling? In this case, there was some mild suprapatellar effusion. So there was some swelling in the knee. The TPP means tenderness to palpation. He was tender to palpation over the medial joint line. He had a positive McMurray sign. There was crepitus or grinding when we try to move the knee, so with range of motion. He had a grade 1 Lachman test, and it was negative for the posterior drawer. There was a stable varus and valgus stress when you moved the knee, but the patient had a pretty good range of motion. It was full. There were not any limitations with the movement to flexion and extension. Then the strength was actually pretty good. It was 5 out of 5. And then we get into the EHL, TAGS, FHL, and all of these acronyms. Well, actually, I was going to wait for the end, but let's get into this now. The EHL means extensor hallucis longus. This is basically you testing the big toe extension. The TA is the tibialis anterior, which is the ankle dorsiflexion. The GS is the gastrosoleus, and SILT as ITLT over nervous distribution. So you're basically checking that distribution there. The FHL, which is the flexor hallucis longus, this is a lot, I know, but I'll try to do my best to go over this, is basically you assessing the big toe flexion. The TP gastric is the tibialis posterior, is the ankle plantar flexion. And this, I know, sounds like a lot, but it's very easy and very fast when you're basically evaluating this in clinical practice. Then you go to the EDL. The EDL is the extensor digitorium longus, the extension of the 2nd to 5th toes. And then the FDL, which is the flexor digitorium longus. This is the flexion of the 2nd to 5th toe. So let's look a little bit now more deeply at the neurovascular status. And this is something that you never want to miss. You always want to have your neurovascular status. And unfortunately, there have been people that have misses in their assessment, especially for patients that have a poor circulation and getting in trouble, because sometimes these patients end up with amputation. So you always want to make sure that you document and you also evaluate, right, like the neurovascular status of the lower extremities. So NSTLT means normal sensation to light touch. SILT is sensation intact to light touch. DP for dorsalis pedis pulse, and PT for posterior tibialis pulse. These are all very common ortho terms. I do not always write all of these terms in every single note, but you might come by some notes that have all of these jargon or acronyms. And it's a good idea to know what they are and what they stand for and what kind of information you're basically can use or is useful, right, when you're doing your assessment. But don't fear, you don't necessarily have to have all of this in every note that you write. Then we continue here on the objective. Then you want to make sure that you have your labs, your imaging, and when you put your imaging, you want to actually write in the note if it's a right or left and also the date of when this image was taken. And that is very, very important, especially when you're consulting out, because you want to know how old the imaging that you're sending the patient with is, especially if you need perhaps to get or obtain something newer, right? To know what is the current state of that knee. And in this case, there were no available labs at this time, but we did have a left knee x-ray from 2019. It was normal AP and lateral knee x-rays with some mild to moderate decreased medial joint line space. So he does have some osteoarthritis especially in the medial joint line, which what we learned from our assessment was where there was tenderness, right? Then we look at the MRI of the left knee. And this was actually older, from 2018, and there were some degenerative findings as well, a degenerative medial meniscal tear. So basically all of this is pointing to the fact that this patient has a medial joint line pain, right, on physical exam, and it's collaborated also by the imaging findings that we got. So now let's look at assessment and plan. I said it last time, I like to bunch these two together because they really do go hand by hand. You want to have the age of the patient, the gender, the past medical history if it's pertinent, the reason the patient was seen for today, and that fact that based on the history, your physical exam findings, and previous imaging studies, your suspected diagnosis is XYZ. And then also your plan is plan 1, 2, 3. We're going to go over the plan that I created for this one. And make sure that before the patient leaves, you have a plan for the next time you want to see him, a plan for what you want to do next. And this is very important. So in this case, we have a 64-year-old male with a past medical history of hypertension and diabetes type 2 that was seen in the clinic today for acute on chronic left knee pain. So this patient had a chronic history, but he had a flare-up. Why? Because he went to Disney, right? So based on every information that we were able to obtain from this patient, we came to a diagnosis of left knee osteoarthritis with a flare-up pain exacerbation. So he has mild to moderate left knee osteoarthritis. We're not in this case worrying about the finding from the MRI that said a degenerative medial meniscus tear, because it's degenerative in nature. It comes from the arthritis that is happening. So this is, especially also his age is 64. So this is not someone that we're going to rush and run for consultation, because this is all degenerative in nature, and a meniscectomy is not something that's going to help him. So what is our plan? Well, we're going to start with conservative treatment. We're going to start with some weight-bearing left knee x-rays, because if you see, let's go back here, perhaps the x-rays here were not really weight-bearing, and we really want to know like what the status is right now. Then we're going to have this patient lose a little bit of weight. We're going to work on some low-impact exercises. In this case, we decided to use acetaminophen PO 500 milligrams PRN, because of the patient's history of his hypertension, of his diabetes type 2. We want to protect those kidneys. And if we give him oral NSAIDs, which is typically like the thing that we do, then we might affect those kidneys, and we want to protect them. But we can also do topical NSAIDs. These are not readily or 100% absorbed systemically. So this is a good game plan for this patient. Perhaps we also want to do physical therapy. And one key patient teaching is for him to use the cane on his right hand. Why? Because he's basically using it on his left hand, and that is the knee that hurts. What we want to do is use the cane on the opposite side so that we can offload the weight. When we use it on the same side, we're basically putting a lot more weight bearing and causing even more pain. And this is something that is going to help him as well. Many times I try only a few things at a time to see what works, and then have the patient come back a little bit earlier to see what then we can move forward with. Because if you give them everything at once, then they might not do it. So it's better to get things done and get them to do more, but with less to do, so that they can be more compliant with the plan that you have. So in this case, we're going to bring him back in 8 weeks for reevaluation after this plan that we had. Or we also tell them that the patient can come in sooner if the sign and symptoms worsen or they're not improved. You always want to make sure that before the patient leaves, the patient knows what to do and how to find you and when to follow up, or if in cases of like a worsening of symptoms, what they can do, right?
I've said it before, I'll say it again. There are many ways of skinning the clinical cat. That is, there's rarely a single correct one only way approach of doing things. Instead, there are many approaches. However, what I went over today is what has worked for me and what actually speeds my process and my thinking as well. So definitely hope it comes in handy and you get to apply it. Let me know in the comments if you do. The type of notes you will write in the clinical setting will vary. They could be comprehensive or focused. For example, we just reviewed a typical and common knee complaint. It was more focused in nature. That can definitely be a patient that you can see in the primary care clinic, in the specialty setting, in the urgent care, even in the emergency room, because they do come with all these complaints and musculoskeletal knee complaints. So anywhere basically in an outpatient setting. At the start of the video, I mentioned to you that I was going to show you how to access the free ortho guide for nurse practitioners to help you maximize your skills and time in clinical practice. There's a link in the description box also where you can find and grab your free copy today. It will be an absolute game changer, especially if you're not familiar with musculoskeletal care. That is it for now. I'll see you in the following video.